So my name is Joachim Kaufmann. I'm German, working in Norway, and now I want to present my study, the effect of numbers and duration between osteopathic treatments on patients suffering from foot-related problems. And this is, as before, dose-response study. And these are the structure we are working on. These are fascia. So this is the connective tissue between the muscles, between the organs, it's a network over the whole body. If you see this like a sheet you have over the whole body and goes in between all the different structures, and if you draw on one end, you have the effect on the other end, you have an overall effect in the whole body. So this is a picture from the different kinds of, you have more, yeah. If you have more stable structures here, more, if you draw on this end, you have the effect on this end and on this end. And if you see this structure, it's a little bit more fragile, and if you have a scar tissue in this area, for example, then you get a restriction of this area and this area too. And this is what we are dealing with our hands, and that's what osteopathy is about. And the aim of the study is to determine the combination of numbers of treatments and interval between treatments in order to optimize the effect of osteopathic treatment on foot-related pain. And we included 32 female and 22 male patients with a mean age of 42 years and the relatively high body mass index of 27. And all of these suffered from foot-related injuries. The patients reported the injured side 10 on the left side, 17 on the right side, and 27 on both sides. There are 4 different things they can have on the foot to be integrated in the study. This is a twisted ankle. So they have the injury had some days, some weeks, or some months before. They have tendinitis here, seen on the right side. You see it's a double in the diameter than the other side. They have an inflammation under the foot, so it's a plantar fasciitis. Or they have the osteoarthritis. You see it here on the right foot too. So the joint itself, it's much more bigger because the arthritis of the ankle is a fact. And the study is performed as an observer-blinded and randomized single-center trial with 3 high-2 factorial design. And the 2 factors was the number of treatments and the treatment intervals. It's the same as Dr. Glomsrud presented. And the randomization was allocated to 3 different treatment groups, and the nested block randomization was a fixed block size of 18. So you have 18 patients which got 3 treatments, 18 got 4 treatments, and 3 got 5 treatments. And they are splitted into the treatment interval. You see here 7, 10, and 14 days. You see 3, 4, and 5 treatments. So at all, there are 9 treatment groups, and these are the 54 patients included and randomized. And the primary variables, they are the pain at rest and pain at load. They are recorded on the so-called 10 centimeter visual analog scale, the VAS scale, It's pretty much used in the manual field because we have no better instruments which have low cost. Here are 3 different possibilities to have this vast scale. So you have 6 different places where you can tick on or in between. Here you have the 10 centimeters and you can tick on or in between these numbers, or like we used the open scale where you have no pain on the one side and the pain as bad as it could be. And we measured the pain intensity before each treatment, 1 day after the last treatment, and at a 4 weeks follow-up. And additionally, we try to figure out, is there any compound of blood pressure in the 4 extremities included? So has the patient who has problems on one side, has a higher or lower blood pressure on that side, to find out, is there some correlation in this? So here's a visual analog scale, and this is the measurement instrument you could use. We used a more easy one where you just have the line. And this is the measurement from the ankle brachial index. So simultaneously on all the 4 limbs, the blood pressure get measured, and you have a so-called ankle brachial index, which should be around about 0.9 or higher, and that you don't have any problem with your arterial blood flow. You see it here. You have the 4 different measures from the patient, and the blood pressure, the systolic blood pressure on the legs should be 0.9 from the upper extremity or higher. So it's a good tool to find out about the arterial blood flow. So the treatment itself, it's a so-called local treatment. So we had a special session for the osteopaths working on this study. So they learned a little bit more specific way to treat the foot, because I was working over around about 30 years, especially with the foot, but I don't want to be the main part, so that you can say, if you have so much experience in this field, it should be good outcomes. And therefore I integrated 6 osteopaths, Norwegian osteopaths, doing the study, so that you can see that the osteopathy is good and not the therapist is good. So treating the foot in a special way, just a picture that we are working with our hands on the foot. And the general treatment is included in the osteopathic manual treatment. So that is the same as Dr. Glomsø said before. It's a general treatment over the whole body, not just on the back or on the foot. It's the general treatment for the whole body, depending on where the areas of decreased movement is. So that's the main point we are looking for, is decreased movement. And if you see on the different indications which was included in the study, you have decreased movement in all of these cases. But the twisted ankle, you have too much movement. And you see, if you have one part of the body which moves too much because it was a trauma in the background, you will afterwards get decreased movement in other parts. And that's what we are dealing with. Or you find so-called patterns of restrictions, That means you have this twisted ankle and you have a reaction of the whole body to this twisted ankle. You cannot have the same load on the side. You get pain, so you go over to the other side with your weight. You bend your hip a little bit, and some pattern of restrictions. As longer the time is, as more restrictions you will find. And the treatment was 40 minutes. And in this 40 minutes, the osteopath has to document what the finding was, so that you can see is the amount of findings over the treatment decreasing or increasing, hopefully decreasing. And this is the findings form, so where the osteopath ticks, is it the temporal mandibular joint, or is it the cervical 7 or the thoracic 12, or pelvis problem, or something on the upper extremity, something on the knee, something on the fibula. You have all the different conditions you can have on the foot itself, and that's what the osteopath has to take on, and we documented the outcome, and we see here the results. The results related to the number of treatments. The pain at rest was significantly reduced in all 3 groups under the treatment. That was very interesting. The largest reductions was for 3 and 4 treatments. For 3 treatments, the pain was reduced from 3.7 at baseline to 2.5 one day after the final treatment, and 4 treatments was reduced from 3.3 to 1.7, and for 5 from 3.0 to 1.8. And a similar pattern was detected for pain at load, with significantly reduction in all 3 groups. So the 3 treatment group was from 6.0 to 3.1 after the last treatment, the 4 treatment group from 5.7 to 3.1, and 5 treatment group from 5.6 to 3.6. And for both pain at rest and at load, 3 and 4 treatments were found to be superior to 5 treatments. So that was related to the number of treatments. So here we can see the 3 groups. So here's the 3 treatment group at baseline, and if you follow the black part, you can see the decrease of the pain, and here is the day after treatment, and here you see the 4 weeks follow-up. For 4 treatments, you see immediately that the reduction of pain is obvious after the first. The second stabilizes at the 4th and goes down to after treatment, and 4 weeks follow-up, it goes up again. And for 5 treatments, you see at baseline a little bit lower than the other ones. It goes a little bit up and then down and stabilizes on a lower level, but the baseline level is lower too. And here you see the development of pain at load, again related to the number of treatments. You see the black one again. Here you have the high score, so it's much higher than at rest. At load you see the same pattern, go downwards for the 3, 4, and for the 5 treatment group, but the amount of how much it goes down was highest for the 3 and 4 treatment group. If you see the results related to the duration between treatments, so again, here at rest, so pain at rest was significantly reduced in all groups related to the duration between treatments. In the group with 7 days treatment interval, the pain at rest was reduced from 2.9 to 1.4 over to 1 day after the final treatment. For 10 days, from 2.9 to 1.7, and 14 days interval from 3.7 to 2.4. And for pain at rest, 7 days duration between treatments seems to be the superior choice. So as we have seen before, 3 or 4 treatments, and now 7 days rhythm. And here we see the development of pain at load. You see again, it's a much higher score in the 3 groups. And what is special, that you see that the 7 days interval group, they have a very high spread. So that that's maybe related to, I will come to back that in the discussion. And the pain at load was significantly reduced in all these 3 groups. In 7 days treatment, the pain was reduced from 5.9 to 3.9, and the 10 days group from 5.2 to 2.7, and the 14 days interval from 6.2 to 3.5. And here, the 10 or 14 days treatment interval was found superior to 7 days regarding to reduction in pain at load. So here, once more, the development of pain at rest and at load. And if we see the interaction between the numbers and duration between treatments, you can see the reduction in pain at rest. The superior combination was 4 treatments with 7 days treatment interval. And for the reduction in pain at rest, it's wrong, should be pain at load. The 4 treatments gave significantly results both for 7 and 10 days treatment interval, but 10 days was found to be the optimal combination. So you see here 4 treatments in 7 days for the rest, and at load you see 10 days, also 4 treatments. So it's a different what kind of pain you're working on. And the number of treatments seems to be the dominant factor with regards to both reduction of pain at rest and at load. And an increase of number of treatments, recommending increased duration between treatments in order to keep the significant reduction. So they are depending on each other. It seems so that 3 treatments are not enough input, and 5 treatments seems to be your overload, and 4 treatments seems to be the right amount. And so that is a discussion going on. Is it related to the recovery time? So that means the duration between treatment. What is it depending on? So it seems so that a low score needs to have a shorter rhythm, and a high score needs to be a longer rhythm. So you see the pain amount at rest, which was much lower in the pain at rest, and we found that the treatment rhythm was 7 days. And the higher score in the load group, in the load pain, you see the longer rhythm was 10 days. So the pain occurrence can have an effect too. So you see that the 4 treatments with 7 days at rest was the best related to the number of treatments, and at load the 10 days was best, as I said before. And That's one of the critical parts. We have just 54 patients in 9 groups, so 6 patients in every group. And we can trust the results even more if we have more patients, so the results will be more exact. And the conclusion is that the combinations of obtaining the largest reduction in pain at rest and at load seems to be 4 treatments with 7 and 10 days treatments interval respectively. Thank you for your attention.
Questions? No questions? Microphone.
I can speak now. When did you, how long after the incidents or the trauma did you start treating the patient?
So we started, we got the patients from the medical doctors in Bergen, and that was not a factor how long ago they have had the injury. So they came with acute, with chronic pain. So that was not one of the factors, because in osteopathy we treat all of them, and that's the main point. If they come to the praxis, they should get the treatment. If you cannot work so much locally, because there's inflammation, there's so much sensitivity if you touch the area, we have enough to do with the rest of the body, so we can work at all with them. So that's the background why we don't thought about how long it was ago.
Yeah.
You had the observation that the conclusion of the study was a lengthening of spacing was actually more beneficial between treatments, the duration, the length, right? Don't come the next day.
Yeah.
Wait some time, and some lengthening of that turned out to be more beneficial. Is that right?
Yeah, if you have a too short rhythm, then the impact of the treatment is, the dose is too high,
Right.
and then you get an overreaction that the pain goes up.
So there's some curvature on the body's ability and time to recover and assimilate the benefit of the treatment that you were given.
Yeah, so the recovery time is depending on how much structures are involved and how big the degree of less movement is. So if you have a patient, for example, with plantar fasciitis, and he has very restricted joints, and you give too high impact in the treatment that he can move much more better, the inflammation process in the restricted plantar fasciitis get more pain. So you just give a little bit more movement from one treatment to the other, and then you have not the bad effect. So that is a special how we deal with the foot problems where you have so much load on it. And you have seen that there was a lot more women included in the study. And that's the fact that women has much more feet problem because they use shoes which are not very good for the feet.
Yeah, question? Give her the microphone.
How long is the treatment time? I mean, in terms of treating.
So each treatment was 40 minutes, and in these 40 minutes, the osteopath has to scan over the whole body to find all the places where he maybe should work afterwards. So that is depending on the osteopath, take around about 10 minutes. And afterwards, he has to decide what is the condition of the patient, where he has pain, can I work on the pain area, can I work on other areas. He has to make his osteopathic treatment of 30 minutes, and this is every time the same. So the hands-on work around about 30 minutes, but the brain is working 40 minutes.
Okay, so that's the 40 minutes weekly interval for 4 times is your best.
Yeah. Thank you.
Dr. Kaufmann, and I'm